Hey everyone, welcome to The Explainer. I'm your elite board tutor today, and we are going to absolutely hack the exam when it comes to superficial and subcutaneous mycoses. We're stripping away the fluff, right? Just focusing exclusively on those high-yield diagnostic patterns and the classic traps that examiners literally use to wreck your score. So get ready to hardwire these concepts into your brain. Let's do this.
But first, I want you to just consider this clinical vignette for a second. Imagine a premature neonate on parental lipid nutrition suddenly spikes a fever. Blood cultures are drawn, so what lipophilic yeast is the culprit here? Hold that thought. Lock that scenario in your mind because the answer actually unlocks one of the highest yield concepts in medical mycology.
Okay, here is our high-yield blueprint for today as your ultimate study map. We're going to cover 1. Superficial fungi, scaly traps. 2. Dermatophytes, rings and nails. 3. Sporothrix, the rose thorn. 4. Deep fungi, grains and cells. And finally, 5. The exam trap room. All right, let's dive right into section 1, superficial fungi, scaly traps. So starting off with a major surface threat that just loves to disguise itself. And guys, I cannot stress this enough. Do not let the examiner trick you on presentation. We're talking about Malassea furfur, right? The organism behind Tinea versicolor. Say a patient comes in with flat, round, hypo or hyperpigmented patches on their chest or back. Is it Tinea versicolor or is it vitiligo? Well, the absolute key difference, like the single word you absolutely must look for in the question stem, is scaly. Tinea versicolor is scaly. Vitiligo is not scaly. So if the lesion has scales, cross vitiligo off your list immediately.
Now, when you actually take a scraping of those scaly lesions and do a KOH prep, you're going to see a classic pathognomonic buzzword pattern, spaghetti and meatballs. Yeah, it sounds a bit gross, but hey, it is totally unforgettable. This refers to the mixture of short septate hyphae, that's the spaghetti, and bottle-shaped budding yeasts, the meatballs. When you see spaghetti and meatballs or even short septate hyphae with budding yeasts, just click Malassea and move on. Boom, you've just scored a point.
Okay, let's loop back to our opening hook. Remember, Malassea is a lipophilic yeast, meaning it literally loves fat. So in the lab, to culture it from something like a back folliculitis, you actually have to add olive oil to the medium. Clinically, this totally explains our neonate vignette. Premature neonates receiving IV fat emulsions, parental lipid nutrition, are just a massive breeding ground for this yeast. The IV lipids literally feed the fungus, leading to fungemia. The absolutely crucial treatment step: you must stop the parental lipids, take out the central venous catheter, and hit them with amphotericin B or an azole. Moving right along to section 2, dermatophytes, rings and nails. Now we're moving slightly deeper. Let's look at the classic ringworms caused by trichophyton, microsporum, and epidermophyton. And this brilliantly illustrates exactly how examiners are going to test you. They're not just going to ask, what is ringworm? No way. They will test your ability to differentiate the syndromes based on patient demographics and really distinct clinical features. Take a look at Tinea capitis. You want to look for a child, maybe 3 to 7 years old, with scaly patches and hair shaft breakage. Then you've got Tinea corporis, which is your classic annular or ring-shaped lesion with an active, scaly border and central clearing. But hey, pay super close attention to Tinea cruis, jockage. It occurs almost exclusively in men. And the massive exam trap here, it's the border. It has discrete borders and absolutely no satellite lesions. If the stem mentions satellite lesions in the groin area, you're dealing with candida, not a dermaphyte. Now, I want to pause here for a second and talk about Tinea pedis, athlete's foot. We so often dismiss it as just an itchy annoyance in the web spaces of the toes, right? But on the boards, Tinea pedis is a loaded gun. The maceration and peeling actually create fissures, and these microscopic cracks act as a major portal of entry for some really serious bacterial infections. So when a patient presents with sudden lower limb cellulitis, the underlying enabler was very often Tinea pedis, letting Streptococcus or Staphylococcus slip right past the skin barrier.
Before we leave the dermatophytes entirely, let's talk about nails, onychomycosis. Thickened, crumbling toenails usually require systemic therapy, and the absolute board favorite comparison here is terbinafine versus itraconazole. Terbinafine is going to be your first-line systemic choice simply because it has significantly fewer drug interactions. Itraconazole definitely works, and it's often used in pulse therapy, but it brings a much heavier baggage of interactions. And remember, even with the absolute best therapies, including topical solutions that take literally an entire year, relapse rates are stubbornly high at 25 to 30%.
All right, section 3, Sporothrix, the rose thorn. As we hunt down the thermal dimorphic fungus, Spirotrix, you absolutely must think of a highly specific sequence of events. Step 1, traumatic inoculation. Classically, this is the rose thorn prick in a gardener, or increasingly a cat scratch, especially if you're looking at cases in Brazil. A papule forms. Step 2, that primary lesion ulcerates. And then step 3, and guys, this is the absolute giveaway, sequential ulcerated nodules begin to ascend along the lymphatic channels, moving proximal to the original lesion. So when you see ascending lymphangitis or nodules ascending the arm, you must think Spirotrix.
Now, what's really interesting about this next bit is the histology. If you biopsy that lesion, you're going to see a mixed granulomatous and pyogenic reaction. But the pathognomonic finding, the buzzer you need to hit, is cigar-shaped yeasts. Yep, if the question stem mentions oval or cigar-shaped yeasts on special stains, the diagnosis is confirmed for sure. Examiners just love testing Spirotrix treatments because the traps are literally everywhere. First step, itraconazole is the drug of choice for lymphocutaneous disease. Expect a 3 to 6 month course. Second, there's this old school alternative called SSKI, or saturated solution of potassium iodide. It's cheap, sure, but it's an exam favorite because of its terrible side effects, like metallic taste, salivary gland swelling, and rash. But you want to know the biggest trap? Voriconazole? Voriconazole is entirely ineffective against Spirotrix. Do not choose it, no matter how tempting a broad-spectrum azole might look on that screen.
Moving down to section 4, deep fungi, grains and cells.
Entering the territory of really chronic, disfiguring subcutaneous infections, let's look at Madura foot. It's characterized by massive swelling, sinus tract formation, and visible grains extruding from the tissue. Now here is the critical clinical crossroad. Only about 50% of these mycotomas are actually fungal, what we call eumycetoma, which often presents with black greens. The other 50%, they're actinomycetomas, which are bacterial. And clinically, you just cannot reliably tell them apart. Because of that, a biopsy and culture are absolutely mandatory. Why? Because you treat the bacterial version with antibiotics and the fungal version with massive surgical excision and long-term antifungals. Guessing wrong here is just disastrous. Next up, we have chromoblastomycosis. This presents as painless, nodular, verrucous, plaque-like lesions on the lower extremities, usually popping up after some traumatic inoculation from soil or a plant. The secret to answering this question correctly lies purely in the histopathology. You are looking for one specific phrase, muriform cells. These are also known as sclerotic bodies. They're these copper-colored, thick-walled, multiseptated round cells. Listen to me on this one. If you see muriform cells or copper-colored sclerotic bodies, it is pathognomonic for chromoblastomycosis. Lock it in. But do not let the slow, painless nature of chromoblastomycosis fool you into complacency. There's a really deadly downstream effect here. A rare but incredibly severe long-term complication of this chronic inflammation is the development of squamous cell carcinoma right within the lesion. Examiners love to test long-term complications of indolent diseases, and this one is a prime target. And finally, Section 5, the exam trap room. Let's synthesize this. Okay, we've covered a ton of ground today. So the crucial point now is that you must recognize the exact places where students drop points. Here are your top 5 rapid-fire traps. Number 1, vitiligo is never scaly. If there are scales, it's versicolor. Number 2, tinea cruris has no satellite lesions. If you see satellite lesions, pivot straight to candida. Number 3, voriconazole fails completely against Spirotrix. Use itraconazole instead. Number 4, terbinafine is your first-line systemic for nails due to fewer drug interactions. And number 5, Malassezia thrives on IV lipids. Neonate, TPN fever, stop the lipids. Now I'm going to leave you with this final thought to really test your mastery. A male landscaper presents with painless, verrucous lower extremity plaques, which is classic for chromoblastomycosis, but he also has ulcerated nodules ascending his lymphatic channels, which is the absolute hallmark of Spirotrix. Wait, so which fungi are we actually dealing with here? Or is it a coin infection? When clinical presentations overlap like this, histopathology becomes your only map out of the woods. Are you looking for muriform cells or cigar-shaped yeasts? I challenge you to review these nuances, study the diagnostic patterns, and never fall for an exam trap again. Until next time, keep studying hard.